Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay. So I welcome all my dear students in the class tonight, especially the ones who are going for the practical tomorrow. Very, very important class for you people. I'll not waste your time in tonight's class. I'll not be waiting a lot for the answers. It's going to be mostly question, answer class. We will not be waiting and spending a lot of time. I want to wind up this class as early as possible by just giving you the tips and tricks into understanding the questions and answers. And if suppose this kind of question comes, what should be your approach? All right. Now I have a mixed bag of a lot of OSCE. Some of the OSCEs were there in some of the different exams. Some of the OSCEs were there in some of the these classes that they take, mock classes, mock Viva classes they take. Some were there from the net. So I have mixed all of them together and I've tried to give you a good bundle. Now let me see how many students are there who've joined. And okay, if we have enough of the participants. So first of all, a lot of blessings to all my students who are going for the practical tomorrow. Believe me, it feels like I am going myself because I have trained you, I have coached you, I know your weak points, I know your strengths. Tonight is a night to focus on your strength. All right, guys. Up till now, I used to feel that there is this kind of motivating talk doesn't work, and all these things, they really they're just wasting time. But believe me, right before the examination, the worst thing that you can do that puts you behind the others is panic or trying to do a lot of things at the last moment. Just have a little bit of calmness inside of you. Just have that confidence that whatever I have done up till now, let that percolate inside me. Let it stay inside me. Usually these things, they have real bad cross connections. And in front of the examiner, you get half the time you usually get in your theory answers. Okay, in theory, you're far more composed and calm because you know the time is in your hand. You can go back to the question and write it down. But in front of the examiner, you have to answer there and then. And examiners, they judge you on all these things. Your, strength is calmness. Even in the crisis situation, if you're panicking, you will end up doing blunders. You end up saying stupid things which examiners get irritated by. If you try to show that you're very smart, none of the examiners are going to like it. So have a very humble attitude, have a very calm attitude. Politely say, sorry, ma'am, it's not coming in my mind right now. It's fine. It's absolutely fine. That's the best answer that you can give. Sorry, ma'am, I'm not able to recollect. I'm a little nervous. That's okay. Examiner might tip on the end of passing you. But if you try to, speak syndromes and rare things, that is counted as being overconfident or oversmart. None of the examiners like it. Do not end up irritating them. That's a very important tip, whether you want to take it or not. It's very, very important. I have judged students. I keep judging them as well. The way they answer, the demeanor, everything matters a lot. How you perform under pressure is what finally matters. None of you, believe me, all of you sitting right now in front of me, none of you is 100% prepared for tomorrow's practical. But what you're prepared with, you have to be confident with just that. I know my students, I know all of you. I have been getting frantic, very panicky calls, messages since morning that, ma'am, please, we need a little booster session tonight, which is why I've started with it. All of you know sufficient enough to pass the exam. And I again repeat, examiners sit there to pass you, not to fail you. They have that soft corner. All of them have been through the stage. Until unless some of them may be like that, but very, very, rare circumstances you'll get to meet such examiners. And, there is a whole committee of examiners, not just one. So one might flunk you, but the others are there to support you. So the only bad thing that you can do tomorrow is a lack of sleep tonight, a lot of studies tonight, or a lot of crisscross connections in the night. Take a good sleep. Preferably do not study anything after my class. All right, that'll be good. I'll go slow, but I'll go in such a speed in which, how do we join the live stream? Jitu, if you're there in the class, Akash, if you're there in the class, there's a girl, Sakshi, please help her out in joining the stream, the main stream, the live class, please. Okay. So yeah, coming back. So please, the worst thing that you can do tonight is to panic, is to study a lot, keep studying till late at night, skip your sleep, get up early in the morning, start studying again. No, none of that you're going to do. Just promise me that you will sleep properly. You will have an 8-hour sleep. You will not get up early in the morning, and you will not go through your books. If you get up early in the morning, just pray, meditate, do anything to relax your mind. Believe me, girls and guys, it's going to help you tomorrow. You need to keep your mind sharp, focused, calm, and easy. You'll get a lot of time for your case presentation, history, viva, everything, to present your case, to prepare for your case. You'll get enough time. OSCE, I'm telling you again and again, you can never be fully prepared for OSCE. So please be very calm while you're doing OSCE questions. It's fine if you skip a question. It's fine if you're not able to come to some conclusion. Believe me, OSCE stations are not difficult. Okay, they are very oft repeated and expected questions, so it's not going to be difficult for you to pick up what it is. Just in case you are not able to pick up whatever it is, even then you've lost only just 3 to 4 marks. You have a lot of stations to cover it up. And at any point in time, if you still feel that I'm not doing well, please, girls, keep your sanity intact. Okay, perform better in the next session. That's all you have in your hands. You do not have anything else but to perform best. That's all I'm saying. With those thoughts in mind, let's begin tonight's session, because in that case we'll become very late and my whole purpose of taking the class will be lost. All right, so let's start with the session tonight. Let's start with the first slide. See, they're that easy. Now I can just by the picture I get what it is, but I'll still read the history. It's a 28-year-old woman. She's second gravida, para 1, with previous cesarean. So it's like adding on to what I was expecting. Got admission tertiary care center with APH. Okay, pallor 3+, pulse. She's having tachycardia, hypotension. She's lost a good amount, at least 30% of blood volume she has lost. Maybe even 40%. Uterus 32 weeks, cephalic, but the FHS is there. That's very important. PV bleed is plus. She's not taken, she does not have any antenatal records. Emergency cesarean section was done. Placenta was anterior low-lying. It was adherent. Blood loss was around 500 ml. Vitals were stable. Uterine conservation with the shown procedure was performed. Now, where this question is difficult, it's giving you so many hints. Yes, absolutely. This is what I like. Please keep answering. You know the questions are there in front of you. Please keep answering, because I don't think I'll be able to stop for your answers tonight, guys, because my lovely students for practical tomorrow, I don't think it's justice with them to keep stopping for your answers. I'll just do question answers, and I'll not be waiting a lot for your response. Thank you so much, Asha, Osha. Very good. You people have been very fast. I want everybody to keep answering the questions, because you can see the questions right in front of you. Yes, definitely. It's a uterine artery embolization. As you can see, I've taken an elaborate class on this before. I think when I was doing fibroids, proper procedure, everything I have taken up. So this is uterine artery embolization. Excellent, Praveen. Which substance is used to achieve this hemostasis? It's exactly my answer. Have you seen my slides or what? It's exactly my answer. PVA gel foam. That's absolutely right. These are the two things which I have also written. What are the complications of this procedure, guys? I'll tell you. I have a whole table in front of me in which the immediate complications I have given, the post-op complications are there, and then later the remote complications are there. So there is a whole table, immediate and then post and later on. So yes, you have something which is called as, usually what happens immediately is groin hematoma, okay, avulsion of the artery. These things are very sudden. And then post-embolization syndrome happens maybe 2 to 3 days later, in which you have fever, discharge, and you have a lot of pain. So all these things are the complications. I'll be showing the slides, don't worry. In case of bladder invasion, now that was a question asked by one of my students. I would preferably leave the placenta there. Okay, but I have to be I'll not be able to sleep that night, because if the placenta has been left inside, it can have any course of action. It can bleed, it can stay like that. But if it starts bleeding, then emergency cesarean hysterectomy, and then, a lot of, because it's adherent to the bladder, then what, sutures on the bladder, putting the catheter in situ for a long time. So all these things are there. All right, so Thank you, Praveen. You're such a sweetheart. Thank you so much for helping out my student, whoever's there. I hope Sakshi, was she? Please join the live stream because it's very important. I'll be going fast and try to finish it off in time. It's a uterine artery embolization. PV and gel foam are used, guys. Okay. This is the table which I wanted to tell you: early and late complications and immediate complications. So groin hematoma, the aortic dissection because you're threading through the aorta, arterial thrombosis, reaction mass media, you can say sudden spasm that can happen, and non-target embolization. These are very, very, very common and immediate. This is basically for fibroids and adenomyosis. You can always blame it for, this uterine artery embolization for placenta percreta syndrome. As I said, early complications within 30 days, you can have post-embolization syndrome, pain, fever, nausea, malaise, pain. I said that, discharge. Urinary tract infection and DVTs, they are very, very common in the early complications. And late, you have vaginal discharge. This I would not say, but yes, endometritis, amenorrhea, these things can also happen because you've tried to, occlude the uterine artery, correct? So what ACOG says as the gold standard, they say placenta percreta with bladder invasion, you have to do cesarean hysterectomy. This is as per ACOG guidelines. Okay, that's the gold standard. But the other way is to deliver out the baby, leaving the placenta in situ, watching with caution. Nobody is going to do anything, they're not going to fail you for giving it this second wala answer. No problem at all. All right. But you have to be very, very watchful in this second option. Okay. First is cesarean hysterectomy, but again, it will be very difficult hysterectomy because the bladder is right there being invaded literally by the placenta. So to take it out piecemeal, to leave some part of it, to leave some part of the, even uterus clinging onto the bladder, that you might have to do. It will not be a clean cut hysterectomy. Some people do subtotal hysterectomy. Believe me, that doesn't work very well because the actual problem is in the lower segment, especially with respect to the bladder, with respect to the bladder. So that can keep having hematuria and so many other different complications. No one, believe me, no, Viva of the postgraduate students will go into that direction because placenta accreta syndrome, if you have witnessed, if you have assisted, that is enough for you. No one is expecting you to go and manage it. Okay, so intricate details are not going to be asked. All right. All right, now what is this? What is the maximum dose of lignocaine without epinephrine? So I have an answer, beautiful answer for you. Okay, it's a very favorite question these days, not just for this, but so many other competitive examination. Okay, all right. Keep answering, guys. Please keep answering. Like I said, I'll not be stopping for any answers. So maximum dose without and with. So if it is lignocaine with epinephrine, the dose we need is around 7 milligram per kg, and that without epinephrine, what did I say? 3 milligram per kg. Okay, you'll be able to see the answer anyways. 2 points indicative of toxicity of lignocaine. So whenever there is a usual toxicity of any local anesthetic, what happens is you have a paresthesia of the tongue, and here you get circumoral numbness. Usually that is the allergic response with most of the allergens, isn't it? The tongue starts feeling heavy, swollen, paresthesia is there, and this circumoral numbness is there. So that is the same thing over here as well. You find the patient has developed systemic toxicity. So what solution would you immediately require for the management? So I think by now people have been through your competitive exams. I think even they ask you. All right. So it is the lipoid emulsion. All right. And the dose 20%, you have it. And how much ml and everything is included in the slide to come. And exact dose and everything will be provided to you. What procedure is depicted in the picture? So it's very, very obvious. What do you see over here? I think I've taken one of the OSCE stations before as well. You have this particular part is actually the pudendal nerve, right? So what are we doing? We are giving a pudendal block. And I've even told you over here, if you do the pudendal block, how far you have to be from the spine. So it's around 2 centimeters, 1 to 2 centimeters away from the spine. You feel for the, this spinous ligament, and you just give a block there, right? So over here, if you drift a little more lateral, you might end up injuring the pudendal nerve, the inferior gluteal artery. So please stick to just 2 centimeters away from the spine, right? Which nerve roots? So pudendal nerve block, come on, pudendal nerve roots, everybody knows S2, S3, S4. If you've seen my anatomy lectures, I think all of you should know that pudendal nerve I've taken it in, a lot of depth, a lot of, sincerity. Why? Because it's a very important nerve supplying the perineum, and will keep coming until unless you really know about it. So pudendal nerve roots are S2, S3, and S4, which is my next slide. So lignocaine with epinephrine, 7 milligram per kg. Without epinephrine, 3 milligram per kg. Okay, so this plus this becomes more, becomes more, and this without this becomes less. So automatically, plus becomes more and minus becomes less. So plus is 7 and okay, and minus 1 is 3 milligram per kg, right? And I answered this too. Lipid emulsion, you have 20% followed by an IV infusion. So this is basically, people are just going to expect of you this particular part. Intralipid 20%, that's it. Let me just mark it properly so that you can always remember just this much. Intralipid 20%, that's it. And pudendal nerve block, as I already told you. Now this one is very easy. Thankfully, after so many slides that you people have sent me, this one by far was the most clean slide. I can make some inference right by looking at it. So this is a history. See, recurrent abortions, G4A3, 8 weeks dates, presents with this ultrasound report. She is sure of her dates. What do you think it is? So when they ask you the diagnosis over here, see, what I see over here is an anembryonic pregnancy. But if they would have told me the gestational sac diameter, they would have told me, the weeks, they've already told me 8 weeks. But if they would have told me the gestational sac diameter, I would have been more confident in saying that this is a missed abortion. But right now, all I can say, yes, you can say blighted ovum, you can say anembryonic pregnancy, because all I can see is just the gestational sac. I cannot see the embryo. And it looks like a pretty big gestational sac for 8 weeks. 8 weeks, you should have been, you should have seen an embryo. All right. But if they would have given me the sac diameter, the mean sac diameter, MSD, it would have been rather easier for me to say that this is a missed abortion. But right now, I'll stick to anembryonic pregnancy or blighted ovum, right? What are the ultrasound criteria for the diagnosis of above condition? So let me tell you this, guys. Please remember this forever. This is what your examiners want to hear. The mean sac diameter more than 25 millimeters with no embryo, or CRL more than 7 millimeters with no heartbeat. That's what they want to hear. That's all they want to hear. These are the ultrasound criteria for the diagnosis of missed abortion. And if you're sticking on to an embryonic pregnancy, well, MSD more than 25 millimeters with no embryo. That's it. That's what we call. And list 4 important investigations which you require in this case. So you have a whole list of recurrent, you can write this down, guys. Let me tell you, the more you practice writing, the better you will become in everything. Believe me, this is picture memory, and it comes to your mind, and it comes to your mind very solid in your exams. I think I have said this thing many times during my theory lectures. All those students who've got my, this theory course, they keep listening to these lectures of mine, and I keep giving them tips in between. So if you feel that lectures are really boring and I know I just need to read from the PDF notes, remember there are a lot of tips and tricks I keep telling in between. Even I don't know when and what would I say. So right now, like I'm saying, keep practicing writing down. It just superimposes the concept. You do not forget, you do not fumble, and you do not mix up if you've written it down somewhere. So you can write down here also in the chat just for practice. Okay. So yeah, you have a list of those investigations I've given you for recurrent pregnancy loss. You can name any 4 important investigations for the recurrent pregnancy loss over here, which is going to stand here as well. So it's an anembryonic pregnancy or a missed abortion. Slightly, see this, I would have been rather happier. The questions become a little ambiguous without MSD. So I can't say missed abortion. If I cannot say missed abortion, or many things which are to come are not exactly accurate. So if these two, no embryo seen at MSD more than 25 and no heartbeat seen at CRL more than, this is basically a criteria for missed abortion. Over here, I can't say this is missed abortion, but yeah, likely so, because there is no embryo formed at 8 weeks, and she's very sure of her dates, right? So it's more of a missed abortion, and these are the 2 criteria of missed abortion. Still, I'll call it an embryonic pregnancy. And like I said, so many investigations I have given you for recurrent pregnancy loss, YHSG, Mullerian abnormalities, YTVS, any abnormality inside of uterus or polyp or anything that could be a cause, a big cause for recurrent losses, a polyp or whatever. APLA, you know, obviously, POC of karyotype, POC karyotype or karyotype of parents. This is very, very important when you're talking about recurrent pregnancy loss. But the idea is to give first, you know, the karyotype of the POC. If something comes out, you know, abnormal in that, then you go for a karyotype of the parents. Remember that. Okay, that's how you go. But I have written this down together. Why? Because this case, she'll probably be having, obviously, a suction evacuation or DNC. Yeah. Obviously, I'm not talking about pregnancy HSG. They're just asking you about investigations for this case. So when she's already had her abortion and everything, then in that case, for recurrent pregnancy loss, you will be doing. If you have any other investigations right now, see, APLA also you don't do in pregnancy. Okay, TVS. Obviously, I'm not talking about the TVS of the pregnancy. I'm talking about later on. So all these investigations, remember, they're investigations post-pregnancy. Why? Because you want to find out why is she having recurrent pregnancy losses. Okay, in pregnancy, there are hardly any, except for the maybe karyotype of POC. But that also POC means obviously the pregnancy is gone now. There are hardly anything that you will do during pregnancy to find out why is she having a recurrent abortion, right? So all these investigations which they are asking of, they will be done post-pregnancy. Can anybody quickly tell me, APLA, what time do you do? How long after the pregnancy do you take the first test of APLA? And do you settle down with one, you know, increased report, or you know, rely on 2 reports for antiphospholipid antibodies? Quickly, guys. In the meanwhile, I'll just change the slide so you can ponder over this slide now. Okay, you do not do antiphospholipid antibodies in the pregnancy. You do it at least 6 weeks after the pregnancy, and you at least require 2 such samples. Very good. 12 weeks apart. Usha is the star. Usha is really my star. In every which way, she's the star. Very good. Good. I'm really, really happy. Now, again, this was a slide which was horribly, you know, the way it was captured and given to me. I had to ask one of my students, what am I seeing? What am I looking at? Okay, so anyways, this is slightly a better picture. I can see I can see the tube and ovary here. I can kind of see the tube here, and something is coming in very close to the ovary. Okay, usually hematosalpinx, you know, the tube is going to rupture but not go to that level. Okay, so this is most probably a torsion, ovarian cyst torsion, ovarian torsion, whatever you may call it, most probably a torsion of the cyst of the ovary, correct? So that's the diagnosis. And, you know, this level of darkness, that means it's, you know, literally gone into gangrene and you'll have to excise it out. Which are the 2 common risk factors for this condition? So the answer is a cyst. Any cyst more than 7 centimeters is a, you know, it has a predilection for getting torted. And usually dermoid cysts, when they talk about torsion, it usually happens in the dermoid cyst. So dermoids are very, very, very predisposed for torsion. What are 2 common presenting symptoms? The 2 most important presenting symptoms are pain, acute, severe pain. That is the most important, okay? And yeah, acute abdomen, pain, distension, you know, sometimes bowel sounds are absent, constipation, these are all presenting symptoms, okay? Peritonitis, I would not say because it has not yet ruptured. But once it ruptures, then peritonitis, and then it's a whirlpool. Very, very bad. So yeah, heaviness, bloating, constipation, dragging discomfort. These are all presenting symptoms. Gold standard for investigation. Keep answering, guys. Gold standard for investigation will be color Doppler. Yes. Guarding rigidity. Yes, you can say that. Colored Dopplers will be the gold standard for investigation for the diagnosis. And how will you manage it? Well, you will definitely go in for a laparotomy, and you will either untwist it if the condition is not bad, or you will have to excise it if the condition is this bad. As simple as that. So this is it. Torsion of the ovary, cyst more than 7 centimeters is bad enough. It will get any cyst 7 centimeters can undergo torsion, and dermoid cysts are characteristic for having torsion. Severe pain abdomen, nausea, vomiting, sudden onset of pelvic pain. Yes, we forgot nausea, vomiting. We should have said that first. This is more important, right? Color Doppler flow and TVS, very, very important, like gold standard. And detorsion, you can detort it if it's in a uncompromised state. If you see, if you go on the net and you just type torsion of ovary, you'll get a lot of images of torsion of ovary, but not all are bad. Okay. This one was severely bad because it was blackened. In this case, you'll have to excise it. You'll have to surgically remove it. As simple as that.